Hello, ladies and gentlemen. Welcome back to lecture number 2 of arrhythmias. So today we're going to talk about most likely the topic that we're dealing today with is the supraventricular tachycardias. But before, as we talked about the basics in the past video, the basics of arrhythmia and how arrhythmias usually start to generate, we already talked about that in the previous video. And today we're just going to talk about arrhythmias in a clinical way, in a clinical sense, much more than the basics. So let's talk about arrhythmia. Arrhythmia usually is an abnormal electrical activity of the heart, and it can be bradyarrhythmia. It means a lower heart rate which is less than 60, or tachyarrhythmia, a heart rate that's greater than 100. So if you look at it, ladies and gentlemen, the bradyarrhythmias are much simpler. It's basically a decrease in the heart rate. It can happen due to the dysfunction in the sinus. So it could be a sinus bradycardia, sinoatrial block, sinus arrest, AV blocks like nodal blocks or junctional rhythm blocks. All these are the part of bradyarrhythmias. However, tachyarrhythmias, when you see that you have a tachyarrhythmia, you have to find out. Let's say you go into your clinical residency and your chief resident tries to ask you that, can you please detect this ECG and tell me what kind of arrhythmia do you have on this ECG? So the first thing you're going to look at and think to yourself is that if it's a tachyarrhythmia, of course you're going to calculate your heart rate. That's basically the 300 divided by the number of small boxes, right? The number of big boxes, sorry, and it will give you the heart rate. So if you calculate the heart rate and you find out that it's a tachyarrhythmia, you want to find out what's the rhythm like. Is it regular or is it irregular? So if the rhythm is regular, then you want to think to yourself, okay, how is the QRS? Is the QRS narrow or the QRS wide? All supraventricular tachycardias are in general a narrow QRS complex, except the ones that has, for example, a bundle branch block. That's why it's a wide QRS complex. And ventricular tachycardias also have a wide QRS complex. You guys will understand. Let me just draw a picture of heart for you guys, and then we'll talk about why does a QRS become so wide and narrow. Let's say if something is going through a normal pathway, right? This is the AV node, and this is bundle of hairs, and then bundle branches, and it's going through the normal pathway. If this bundle branch is blocked, right, of course the electricity is going to go through here first, through the Purkinje fibers, and then possibly it might go slowly through here, or it might go through this other pathway. So it takes a long time to get to the ventricles. That's why the QRS usually becomes a wider, and it's usually greater than 120 milliseconds in timing. Narrow QRS complex, as you guys know, the supraventricular tachycardias, for example, sinus tachycardia, atrial tachycardia, junctional tachycardia, AVNRT, AVRT, atrial flutters. I will talk about this more in detail in a little bit, but let's first of all just clinically relate this quickly in our mind that, okay, what's my rhythm? Is it regular? What's the QRS like? Is it narrow or wide? And if it's wide, I know that there's a blockage somewhere with the especially if it's a supraventricular tachycardia and a wider QRS complex, I have to know that there's a bundle branch block or aberrancy. Okay, so the same thing with the irregular, you also think about narrow QRS complex or wider QRS complex. Rhythms that are irregular are usually atrial fibrillations, atrial flutter with variable block, multifocal atrial tachycardia, premature atrial contraction. These guys are basically they have an irregular rhythms. And the ones that with a wide QRS complex, like look at this, atrial fibrillation with bundle branch block. That's why it's wider QRS complex, right? The tachycardia, especially the ventricular tachycardias, that's why they're wider QRS complex, because there is so in ventricular tachycardia, why is there wider QRS complex? Let me just explain that one more time to you guys. Let's say there's an ectopic foci in this ventricle. Of course, since this is sending the impulse to the ventricles to this pathway and to this pathway, right? It's not going through the normal normal impulse pathway or conduction pathway, so the impulse is not as fast as it was supposed to be through the normal conduction pathway. So hence there will be a wider QRS complex. All right, I hope you guys understand this, but just a quick review. So when you see an arrhythmia, divide yourself into tachy or bradyarrhythmia. Look at the rhythm. Is it regular or irregular? Is the QRS narrow or is the QRS wide? And then you can just detect your final diagnosis from there. This is just good for a clinical scenario. I mean, when you're in your rotations or when you're in your, like, for example, residency, it kind of does help you a lot. Okay, so now we're going to talk about supraventricular tachycardias. In general, ladies and gentlemen, when we talk about supraventricular tachycardias, we're just trying to refer to as all the tachycardias that arise above the AV node. Many people have different explanation of supraventricular tachycardia. They usually refer to it as the AV nodal tachycardias that arise anything around the AV node, for example, preexcitation syndromes or reentry circuits. These are the nodal reentry tachycardias. They refer to that as supraventricular tachycardias. But in general, if you look at it, anything that arises above ventricles, or sorry, above the sinoatrial node, above the AV node, or the ventricles, we refer to as supraventricular tachycardia. So this is why I will take this and start with sinus. I will start our first conversation with sinus tachycardia. Sinus tachycardia is basically talking as SA node. We're talking about SA node now. So why is the SA node usually going to be increased in heart rate? Of course, the heart rate has to be above 100. Sometimes it can be referred, that's why it's referred to sinus tachycardia. This usually happens in normal individuals due to emotions, exercise, stress, caffeinated beverages, beta adrenergic, for example, anticholinergics, for example, and etc., 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 right? So it's very normal to have increase in heart rate due to some sort of specific normal reaction to the daily life. But however, this can sometimes become abnormal, and it can lead to signs and symptoms of palpitation, chest pain, syncope, and discomfort, like funny feelings in the chest, and possibly even you might have like dizziness and stuff like that. So this is why it's much important to be able to make sure that you can detect a sinus tachycardia from any other abnormalities. And you can usually, with a sinus tachycardia, if it's the treatment is the underlying cause, basically that's the most important thing. You have to treat the underlying cause, and if you cannot treat the underlying cause, then what you do is you just give them a beta blocker, calcium channel blocker, or some sort of beta blocker, calcium channel blocker. That's the most important thing that you basically give them to. There's another medication called Ivabradine. I believe this is how it's spelled, Ivabradine, and it is a funny sodium channel blocker. And it's used usually nowadays. It's been used for sinus tachycardia in case the beta blockers or calcium channel blockers are contraindicated for some reason. Some of the etiologies, if for example myocardial infarction, fever, hypotension, like thyrotoxicosis, hypoxia, and all these sepsis, all these can lead to sinus tachycardia. So remember, ladies and gentlemen, what is a sinus tachycardia? A sinus tachycardia is the increase in the firing of an SA node that leads to abnormal symptoms, signs and symptoms. For example, signs and symptoms of chest discomfort, funny feeling sensations on the heart, syncope. And if it is very problematic and you cannot control it by fixing the underlying mechanism, then give them something like beta blockers, calcium channel blockers, or ivabradine. And that's about it for now. So let's look at the ECG of sinus tachycardia. The one thing is, as I told you guys can calculate the heart rate, right? Let me calculate the heart rate of this ECG for you guys. So let's say 2 boxes, right? So 350 divided by 2 is equal to 100 beats per minute. So I have this patient's sinus. Look, the reason I feel like it's a sinus tachycardia is because I see a sinus impulse generated in this, but however the intervals or R2R intervals are very short, and it's leading to increase in heart rate, and that's why it's sinus tachycardia. Look at the narrowing of the QRS complexes here and here and in here. That's all, as we predicted before, that supraventricular tachycardias are narrow QRS complex, except if they have any sort of bundle branch blocks or aberrancies, correct? That's why then they will be a Y QRS complex. Okay, so I hope you guys understand this, and it's very easy. Sinus tachycardia is I believe, the easiest right now. You can detect it easily on ECG as long as it's a sinus node derivative. You know that it's a sinus tachycardia, calculate your heart rate, and treat the underlying mechanism, or treat them with beta blockers, calcium channel blockers, or vidarabine. That's all good to go, guys. Let's move to the next one. So the next one is premature beats. Of course, atrial premature beats are possible. That can happen. It can usually happen from an abnormality in the atria due to the stretching of the heart. For example, a mitral stenosis can cause that, and any abnormality in the heart can lead to formation of an ectopic foci, for example, from the past, can lead to premature atrial beats. And so what do we do is, how do we, usually it doesn't require any treatment. It says atrial premature beats or junctional premature beats originate near AV node. So it is basically near or around the AV node that they say it's originating. No treatment. It's the only thing is that you will notice the difference between the in the ECG is, look at this, ladies and gentlemen. I can show you guys a little here. Look at this. So you see this P waves are much different from this P wave in here. The P waves in here are not, both of them are similar, and this P waves, if you look at it, these two are so abnormal, right? Not the same as the regular P wave. So that's why it is premature. You can tell that it has actually it's been generated prematurely. And look at the intervals. That whenever there's a premature beats, the intervals are much smaller, and the other time when the heart starts to beat, it's a normal intervals everywhere, and the QRSs are complex, are very normal. Okay, so this is no treatment. Again, premature beats are atrial beats or junctional beats that can arise near or AV node or anywhere around the atria. The P waves differ from the normal waves, narrow QRS complexes, and irregular rhythm. Of course, when you have the premature beats happening, then the rhythm kind of like fluctuates, but in general, the rhythm is normal. So I hope you guys understand. This has no treatment required. Good to go. You can slap your patient and let them go home. I'm just kidding. Yeah, you can safely discharge the patient. All right. So our next topic is atrial flutter. Okay, atrial flutter is basically, let me just explain you guys something. When you see a heart rate of 150 to 250, you know it's called as paroxysmal supraventricular tachycardia. When you see a heart rate of 250 to 350, it's referred to as atrial flutter usually. And when you see greater than 350, it's referred to as atrial fibrillation. So you guys want to just make sure that you keep this in mind. So the atrial flutter is a rapid, regular atrial depolarization from a macro re-entry circuit within the atrium. It means there's some sort of, let's say, I draw this for you guys. For example, let's say some sort of ectopic foci that is causing an re-entry sends an electrical impulse to the atria, and it causes the atria to start conducting impulse through an abnormal pathway and leading to the rapid heart rate and just circling back on its own and causing an atrial depolarization. And it leads to depolarization of the atria more than 250 to 350 beats per minute usually at a time. The rhythm is regular, and the QRS is, as we said, normal unless there's some sort of block. On ECG, this is the ECG findings: 250 to 350 beats, regular rhythm. Let me just go up a little and teach you guys on how. Okay, so look at the rhythm, R2R, right? It's regular. How is the QRS? It's narrow, and we don't see there's a wider QRS greater than 120 milli. So narrow is less than 120 milliseconds. And look at the sawtooth appearance. In here, all these sawtooth appearance, right? These are it's a typical, basically ECG appearance for atrial flutter. And atrial flutters usually can arise from a left heart or the right heart, and basically it's just like one that arises from the right heart is near to the um, annulus of the tricuspid valve, and it can be ablated later on, but it depends on is it left side or the right side, and that has a better success depending on which side it is. Usually the right side has a better success than the left side. Okay, so let's say you have a patient that presents to you with atrial fibrillation. Of course, if he's in an acute situation, acutely unstable, then if, for example, if he has CHF, if he has angina, if he has syncope, if he has chest pain, shortness of breath, you're going to go ahead and do electrical cardioversion for this guy. But if he's acutely stable, then you give him beta blockers, calcium channel blockers, or digoxin. So this is the treatment of choice that you can have. In a chronic treatment, as we said, we're going to give them antiarrhythmics or radiofrequency ablation, depending on which side is the basically abnormal ectopic foci present, or the abnormal part of the atria is this impulse getting generated from. Okay, so I hope you guys understand the atrial flutter. Remember, the atrial flutter is the most important thing, is how to detect, to basically to be able to read the ECG and know the findings on the ECG, and to be able to treat. One more thing we're going to do is we're going to anticoagulate this patient as well, but I'll talk to you guys about anticoagulation later, and with atrial fibrillation in a bit. But just remember, acute unstable electric cardioversion, acute stable beta blockers, calcium channel blockers, or digoxin. That's good enough. I hope you guys understand this one too. We're going to move to the most important topic of today. Oh, apparently not. This is actually not as most important, as we're going to move to the next one. But before we move to this one, let's just talk about, okay, so let's just get rid of this anyways quickly, and then we'll move to the atrial fibrillation. Multifocal atrial tachycardia. If you guys remember, this is abnormal electrical activity of patients of COPD or pulmonary disease. Usually any pulmonary disease can possibly cause this. Pulmonary diseases and COPD, for example, hypoxic patients, sometimes even electrical abnormalities, like for example hypokalemia, and things like hypomagnesemia can also cause the theophylline toxicity, can also cause this thing. So you can remember that multifocal atrial tachycardia. The only thing that you have to do is to understand that multifocal atrial tachycardia do not have any specific treatment right now, except like you can usually give beta blockers, but be very cautious in this patient, because especially if they are pulmonary disease, so they do not usually want you to use beta blockers, especially if it's a pulmonary disease is present in patients. And there's no role for radioablation or antiarrhythmics or electrical cardioversion. So remember that. The best thing is to treat the underlying mechanism of this thing. This, for example, multifocal atrial tachycardia, and you'll bring patient back to normal. Now, when it comes to the ECG, look at the ECG. The only thing that you will notice different is about the P wave. Look at this P wave right here. Look at this P wave right here. So much different. One is smaller, and this one is even smaller. Than the peaks are very, very small, right? So it tells you at least three different P wave morphologies. Rate is around 100 to 180. Irregular rhythm, of course. What do you think about QRS complex right now? It seems that the QRS is narrow, isn't it? It's less than 120 milliseconds. You see etiology secondary to chronic COPD, chronic lung disease, COPD, hypoxia, pulmonary hypertension. Treatment is oxygen, treatment of underlying condition, and rate control. That's all it is. So you don't have to worry much about this, and I promise you, if you look deep into the ECG and find the sinus nodes first, the P waves, and you can find the P waves are perfectly fine, then it's not multifocal atrial tachycardia. But if you find there's different morphology of the P waves, of course, the first thing that comes to your mind is multifocal atrial tachycardia. All right, we'll say goodbye to multifocal atrial tachycardia, and we'll go to our most important topic, atrial fibrillation. All right. So what is atrial fibrillation, ladies and gentlemen? Atrial fibrillation, as we say, that the rate, it's a rapid heartbeat in the atria, especially the atrial beat is greater than 350 beats per minute. So it's greater than 350. It could possibly even go up to 600 beats per minute. So we don't know yet how much it can go to, but up to 600 beats per minute. It is the most common sustained arrhythmia. Incidence increases with age, especially if you're greater than 75. 10% of the population have it. Symptoms is usually the same thing: palpitation, fatigue, syncope. It can worsen heart failure. If patients who have congestive heart failure, they can be worsened by this atrial fibrillation that's caused. So now let's say we have AFib. Let's classify them quickly. We have AFib. So the type of AFibs, I'll just quickly draw this for you guys, is, let's say we have AFib, we have persistent, we have paroxysmal, we have permanent, and we have recurrent, and we have secondary. That's basically, and sometimes even we can have valvular. So that's important thing. So this is the type of AV. Also, I forgot to mention the lone AFib. So what is lone AFib? Lone AFib is basically somebody less than 65 years old with no structural heart disease and presents with atrial fibrillation, referred to as lone AFib. Persistent is that it's present greater than 7 days or requires cardioversion to terminate it. Paroxysmal AFib that terminates very soon, like it terminates off after a very brief period. Permanent is the presence of atrial fibrillation that's present, and it would not go away even after cardioversion is basically performed. And it could be chronic. It can go away, but it can come back again. Recurrent is the basically happening of the AFib again and again, and occurs more than one time. And secondaries, for example, because of congestive heart failure, myocardial infarction. Valvular is because of atrial fibrillation that happens due to some sort of valvular abnormality, for example, mitral stenosis, mitral regurg, or anything like that. Okay, I hope you guys understood this part. It's kind of very easy to classify the atrial fib, but just make sure that you understand that what is a lone AFib, and for permanent or chronic, if you have cardioverted these patients one time, do not attempt to cardiovert them the second time, because usually it's not gonna have any effect on them anymore. Okay, so the etiologies, as we can talk about is myocardial infarction, cardiac surgery, thyroid disorders, pulmonary disease, and all these are the etiologies that can cause atrial fibrillation. How does the atrial fibrillation start? So what happens, as we said, we are going to draw a heart again, and we're going to talk about it in this way. Okay, my drawing is a little bit messed up, but guys, you understand what I'm trying to do. Is let's say there's a foci, right? So an abnormal impulse is basically generated from this ectopic foci. It's being sent to the atria through an abnormal pathway, and this abnormal pathway starts to basically generate a impulse that comes back and starts to fire again and again and again and again, just the same way as an atrial flutter, but however this time this starts to increase the generates much more impulses, and it starts to form atrial fibrillation and increase in heart rate, and it leads to the atrial fibrillation basically. So as we said, it's from an ectopic foci or a reentry circuit. They usually say that they can actually trace, they have been able to trace this ectopic foci to the pulmonary ostia tracing. So basically the pulmonary vein where it enters the left atrium, it's somewhere around there that they have been able to trace it and ablate it later on, and it has been shown to be very good and improvement for symptoms for the patients that have been having atrial fibrillation. So that's how it starts. When we talk about maintenance, like when you see, if you have continuous atrial fibrillation or increase in heart rate. So in long term, it's going to start to lead to the changes in the electrical physiology of the heart rate and the structure of the heart. So the heart will beat faster and faster and faster, and it starts to get enlarged. So the longer you have AFib, sometimes it becomes very hard to bring that patient back to normal sinus rhythm. That's why it's best to terminate the AFib as soon as possible. What are some consequences of the atrial fibrillation? The two most important consequences of AFib is decreased cardiac output. Of course, if your heart is beating so many times, right, you're not filling the ventricles as much as you're supposed to, and hence you're going to lead to decreased cardiac output. And thromboembolic event is because of the stasis of the blood inside the atria, because of the ventricles and the atria are functioning in different timings and in asynchrony. Basically, at different times they start to pump and leading to blood stasis in the atria and form possibly thromboembolic events and lead to risk of strokes. CHAD score is the scoring they basically use to determine the risk of patients who are gonna stratify patients who are gonna develop a stroke from an atrial fibrillation. If your CHAD score is greater than 1, then you're gonna use CHAD2-VASc to determine what's the probability that patient will have a stroke. So the higher the CHAD score, the higher the possibility that this patient can have it's been shown that it's about 8 to 18% chances if the patient has about the higher CHAD score, especially if it's 5 or 6 CHAD score, there's high chance that this patient can have possible stroke in the future. Okay, so ladies and gentlemen, that was it. And then ECG findings, let me just go ahead quickly. Look at the ECG findings. It's chaotically chaotic. The heart rate is usually very fast. Of course, you have to calculate your heart rate. You can see the P waves. You're unable to detect the P waves, which one it looks like everything is like a P wave in here. Look at this. So all this seems like P waves. It seems chaotic P waves out here, and irregularly. It is very irregular. Look at the R to R intervals from here to here, from here to here, from here to here. It's all irregular. The rhythm is irregular, and the QRS is right now narrow because there's no bundle branch block or some sort of thing. But if this was an atrial fibrillation with a left bundle branch block or right bundle branch block, then you would have had a QRS complex that would have been wider. And this is the normal P wave here, ladies and gentlemen, and look at the P waves above. So you can compare these two and you can determine that it's an atrial fibrillation. All right, so no organized P wave due to rapid atrial activity, causing a chaotic fibrillatory baseline, irregular ventricular response, typically 100 to 180, narrow QRS complex and less aberrancy or previous beta bundle branch block, and white QRS complex due to aberrancy may occur following a short cycle sequence, Ashman phenomena. Loss of atrial contraction. There is possibility of a loss of atrial contraction, of course. That's why there is no A wave seen in JVP and no S4 on auscultation, because S4 is the last kick that the atria has when it's pushing the blood to the ventricles, and hence it wouldn't be present, because if it's in a fast rate, it cannot have the last kick. The heart rate will be too fast to have that. What do you mean by the loss of atrial contraction? There's no A wave seen in JVP. So because the atria usually will have, when it contracts, it produces an A wave on GVP, but this is the heart. Since the heart rate is so fast, the atria is contracting abnormally, and you cannot see the A wave in jugular venous pulse, the findings, the pulse formation. Okay, so we understood the ECG part, and it's very easy to understand everything else. But the most important part about atrial fibrillation is understanding its treatment, ladies and gentlemen. If you can understand the treatment of atrial fibrillation, you'll be very happy, because it's a very complicated, to be honest, it's not as complicated, but it's just a lot of medical treatments that you have available to be able to treat atrial fibrillation. But however, in general, remember this rule, race. is rate control, anticoagulation, cardioversion, and etiology. So we're going to go ahead treat. If somebody presents to you with atrial fibrillation, of course, if you want to control the rate, you're going to have to go control the rate with beta blockers, calcium channel blockers, diltiazem, verapamil. If they have heart failure, you're going to use digoxin or amiodarone. If they have beta blockers, calcium channel blockers are contraindicated, then you can use digoxin. The use of digoxin is also preferred. You can use that. When it comes to anticoagulation, remember, ladies and gentlemen, we have to anticoagulate these patients because of what is it called? Because of thromboembolic phenomena that can have thromboembolic events that can possibly happen due to the formation of embolus, and that can lead to the that can dislodge and go to the brain vasculature and cause strokes. So we can use warfarin or novel anticoagulants, for example, epaxaben, dabigatran, rivaroxaban, to prevent thromboembolism. For patients with non-valvular atrial fibrillation, oral anticoagulant is recommended for most patients aged greater than 65 years, or their CHAT score is equal to 1, greater than or equal to 1. So this is for patients who have no non-valvular AFib. Okay, so also aspirin 81 milligram is recommended if patient has. So let's talk about something called we should talk about this CHAT score now. It's a very good time to actually talk about this. So let's say CHAT is 2. So this is CHF, hypertension, age greater than 65, and diabetes mellitus, and stroke, which is previous stroke. Diabetes mellitus and S2. Stroke, which contains 2 points. So this is 1, 1, 1, 1, and then 2. All right. So if it's 0 to 1, you can use aspirin. If it is 2, you use warfarin. If it's 2 to 4, you use warfarin. So basically, the higher the number, you use either warfarin or direct novel oral anticoagulants, which is the fault. The reason they don't use warfarin is because of monitoring of INR and the side effects of warfarin. But however, the novel anticoagulants can be used as well. Lately, it has been approved to be used for atrial fibrillation. All right, so let's say we have also treated the patient with anticoagulation, but how are you going to do if a patient comes back to you and requiring that they have to be, for example, they present to you with chest pain, like the atrial fibrillation, and they are hemodynamically unstable? Of course, if patient is unstable hemodynamically, for example, hypotensive active angina due to tachycardia, uncontrolled heart failure, should be cardioverted immediately. Remember, ladies and gentlemen, if you have any patient that is unstable, the first thing you do is you have to go ahead and cardiovert these patients and let them basically treat them well enough to come back to the normal sinus rhythm. If they are basically stable, then of course what you're going to do is you're going to have to go ahead and treat them with rate controlling medications. That's the most important. What is the cardioversion thing gonna do? What's gonna happen if you do cardioversion, for example? So if someone has atrial fibrillation less than 24 to 48 hours, he can usually cardiovert without anticoagulation. But if someone has greater than 48 hours, what do you do is you have to treat them for 3 weeks prior, and 4 weeks after. 4 weeks after. So if someone has as we said, greater than 24 or 48, anticoagulate them for 3 weeks before you cardiovert them and 4 weeks after cardioversion due to risk of unstable intra-atrial thrombus formation, right? So this is why you don't want to cardiovert somebody who has came after 48 hours, because they possibly can have a thrombus lodged out there in the atria due to the stasis of the blood. And if you do a cardioversion, and that can dislodge right away and it can go cause a stroke. So this is why they kind of put them on 3 weeks of anticoagulation and then 4 weeks after that to not form any thrombus formation. But even if this is after 48 hours and the patient is unstable, still shock them. Or cardiovert them, I'm sorry, immediately. Okay, so some of the etiologies, as we said, hypertension can cause atrial fibrillation, coronary artery disease because of the decreased blood supply to the heart can sometimes lead to the cell death of the myocardial infarction. And valvular diseases can cause that because of the stretching of the heart, and it leads to abnormal atrial foci and stuff like that, pericarditis, cardiomyopathy, myocarditis, atrial septal defects, post-operative, that's a very good one, pulmonary embolism, COPD, thyroid toxicosis. As you see, there's a lot of reasons that can cause atrial fibrillation. So this is, we talked about the lone AFibs and elderly without underlying heart disease. So, and that's about it for this one right now for the etiology. And there is no difference between usually treating with the rate or rhythm control in a long term. It hasn't been shown much difference of treating which one is the best. So both of them have no difference, but it's better to treat with rhythm control than the rate control because of the side effects of the rate control medications. And that's about it, ladies and gentlemen. So usually if somebody has CHF, remember this, that's a good point to be remembered. Try to cardiovert them. If they have atrial fib, try to cardiovert them to bring them back to normal as soon as possible, because they cannot tolerate that atrial fibrillation in patients with heart failure that much. So it's best to bring them back to normal sinus rhythm as soon as possible, since they are dependent on that atrial kick basically, as soon as possible. Okay, so now we're going to talk about another topic called AV nodal reentrant tachycardia. I think I explained in the last video for you guys that what was AV nodal reentrant tachycardia. So AV nodal reentrant tachycardia is reentrant circuit using dual pathway. If you guys remember, I drew this one diagram for you guys like this, and we said that if let's say if the impulse is coming down to the AV node, and the AV node has this fast pathway and this slow pathway, and fast pathway, and then the fast pathway has a long refractory period, and this has a short refractory period. So what happens is that the slow pathway kind of, if for example if the two comes here and they're both in refractory, they will cancel each other out, then the signal will go down. But if one is, for example, if the fast pathway is like, let's say if the fast pathway is sending signals and it's in refractory, and the slow pathway is also conducting impulse, and the impulse is coming down, and it comes here and it sees that the fast pathway, due to some sort of abnormality in the fast pathway, is not in the refractory period, what's going to happen is going to send the impulse back this way, and the impulse will go travel back again and travel again and again and again, make a re-entry circuit and form. If you don't understand this, ladies and gentlemen, please refer to my previous video. I explained it in much more detail, but right now due to the time constraint I cannot explain it much more than this for you guys. So this is an AV nodal reentrant circuit, reentrant tachycardia. So commonly it's idiopathic, although familial AV has been noted. It's usually fast in onset and fast in offset. That's why it's paroxysmal in onset. Fast regular rhythm, it's 150 to 200 beats per minute. Yeah, it's basically something that mostly initiated by supraventricular premature ventricular beats. So it's initiated because of some sort of supraventricular problems, or a foci or abnormality in the AV node or near the AV node, somewhere in the muscle cells or the heart. AV-nRT accounts for 60 to 70% of all paroxysmal supraventricular tachycardia. Retrograde P waves, it means that the P waves are below, and they're basically like, let's say if I have a P wave right now and a QRS complex like this one, what happens, then AV-nRT will have like this. It's going to be lost in here. That's it. So this P wave is lost right here, and I cannot find it. It's more deep inside the QRS, and it's retrograde. It's more down, like pointing downwards than it's upwards. And it's lost in the QRS complex, as we said. So this is why I don't have an ECG for this one for you guys, but if you can look it up and figure out how to, it's usually a narrow complex tachycardia, narrow QRS complex tachycardia, and that's about everything. The rate is 150 to 250 beats per minute, and the P waves are lost. So the treatment for AV-nRT is usually, if it's acute, you use the techniques of Valsalva maneuver or corroded sinus pressure, and if it's not fixed with that, adenosine can be used. Usually they use a 6 milligram initially, and if that doesn't work, then they use a 12 milligram to fix that. And if you still don't have any response, if you still don't have any response to adenosine, you can try metoprolol, digoxin, diltiazem, electrocardioversion in patients with hemodynamic instability. If patients are very unstable, then of course what you're going to do is cardiovert them. In a long term, beta blockers, diltiazem, digoxin, you can use second line flecainide, propofol, and third line catheter ablation. A lot of the times the patients are referred for catheter ablation, and it has been shown to be very successful in this patient population. All right, so we have now our last topic for supraventricular tachycardias, and it's called Preexcitation Syndrome. What is Preexcitation Syndrome? So the Preexcitation Syndrome consists of Wolff-Parkinson-White syndrome and atrial Reentrant tachycardia. So Wolff-Parkinson syndrome, a lot of you guys are very familiar with it, and it's just a quick review of what is atrioventricular. This has been a topic that most of the time it's been very famous around medical students. Everyone talks about it most of the time. It's usually a bundle branch, then an accessory pathway that's that's connection between the atria and the ventricle. It's known as the bundle of Kent. I have mentioned it here for you guys, the bundle of Kent. And okay, this is a little annoying. And so basically what happens, the electrical impulse is generated by this accessory pathway. It takes the accessory pathway, it takes the electrical signals, and it sends it directly to the ventricles without the conduction access through the conduction pathway of AV node, and this is why the ventricles get depolarized much quicker than the normal depolarization time, and it leads to that formation of the delta waves here because of the early depolarization, and leads to that upstroke of the delta wave is produced due to the early depolarization. Some of the ECG findings for Wolff-Parkinson-White syndrome is the PR interval is a very short. Look at this, PR interval is shortened like right here, if you notice this, and the delta upstroke is another one. This is the delta upstroke and the short PR interval, and the QRS is wide because of course it's not going through the normal pathway, it's going through the abnormal pathway, and this takes a longer time for the ventricles to get depolarized, and that's why it's leading to a wider QRS complex. Treatment, as you guys know, the thing is electrophysiological studies and catheter ablation is the best treatment. And if somebody has an atrial fibrillation with Wolff-Parkinson syndrome, this is a high yield question, ladies and gentlemen, then make sure you guys don't treat them with If you treat them with, for example, calcium channel blockers, beta blockers, they will, what happens, the heart rate will further increase, because what happens is if you block the sinus nodes from decrease the heart rate, this pathway is actually taking the signals or impulses to the ventricles, and it's going to further increase the heart rate and lead to abnormal electrical activity of the heart, or arrhythmia. So hence, if you give them procainamide, which is the anti-arrhythmic, and it might control the it controls the rhythm much faster, and it decreases the symptom of the patient, and you can fix that problem on its own. So hence, do not treat them with rate control medication, treat them with anti-arrhythmics. Okay. Another branch of preexcitation syndrome is known as the AV reentrant tachycardia. So this is a little bit like, let me go back to this picture for you guys to show you guys what I'm trying to say. Is the AV reentrant tachycardia is two types. Is AVRT orthodromic and AVRT antidromic. The orthodromic is what happens is the ventricles send, here we go. So the electrical impulse goes from the ventricles to the atria. Here we go. It goes from to the atria, and then it goes through the normal conduction pathway of AV node to back to the ventricles. So from atria back to the ventricles. Hence, normal QRS complex you will see is normal QRS complex, right? This is the orthodromic and travels through normal pathway. Antidromic, however, this is an abnormality that what happens is that the electrical impulse goes from the basically from the ventricle to the atria. So the antidromic rarely stimulus goes through the AV node ventricle. So this basically, the ventricles send the electrical impulse through the AV node. It goes back to the atria and then comes back again to the ventricle. So you see this formation like this, it's going back. So this is why when it goes through the AV node and it comes back to the ventricle, it starts from the atria to the ventricle, it starts to form late, or it takes a longer time, and the QRS becomes wider. So this is the type of two types of, let's say, AVRT is divided into orthodromic, which is the normal pathway with a normal QRS complex, because the impulse goes through the normal AV pathway, and then bundle branches and the Purkinje fibers. And then antidromic is basically when the ventricles sends signals to the atria through AV node, and then the atria sends back to the ventricles through the abnormal pathway, and hence it leads to wider QRS complex, wide QRS. So this is what it is basically, and again, it's an abnormal circuit basically. Like if we have a heart, let's say, you can see that there's atria, and this is the pathways, the accessory pathways that's causing the abnormality formation from sending back and forth the electrical impulse. That's what it is basically. That's called AVRT. Remember, this is not the same thing as AVNRT. AVNRT was paroxysmal supraventricular tachycardia that started near or around AV node, that was circling inside the AV node, and it was causing the P waves were getting buried into the QRS complex. Okay, so treatment. Acute treatment is similar to AVNRT. Wow, this is actually a good idea, right? The treatment is the same. But the long-term treatment is also the same. For example, catheter ablation, flecainide, and procainamide can be used as well. It is just the difference of mechanism of action. The rest is much more like similar treatment as the AVNRT, but it is the mechanism of action of how these two are occurring and forming abnormal electrical activities in the heart. And ladies and gentlemen, for today, we'll stop here, because in the next video what we're going to do is we're going to talk about ventricular arrhythmias and the heart blocks. I will just go ahead and well, I believe you have to review everything. I was going to go ahead and quickly review with you guys one more time, but it's best if you guys watch this video over and over again, and if you understood everything. So that would be much better for you to review it and understand it yourself, and practice some questions to be able to become better at understanding supraventricular tachycardias. Thank you very much, ladies and gentlemen, and talk to you guys very soon in the next video. Take care.